I'm going to provide in the next sort of 10 to 15 minutes or so a bit of an overview of reirradiation and adaptive radiotherapy, particularly our experience on the MR LINAC as well, but again, conventional LINAC approach too. So what is reirradiation? As a concept, we're trying to manage uncertainty. So we've got to take into account many variables before we think about delivering further radiotherapy, either to the same target, a new target that's adjacent, or anywhere else in the body. So a couple of things to consider, potentially the previous radiotherapy information, if we have access to that, and have enough detail in that information to make an informed clinical decision. Measuring the doses to previously irradiated organs at risk, and how proximal is the previous treatment to the new treatment, and how uncertain are we of that previous dose deposition. And we account for all of these different variables as best as we can when completing our RBE calculation, which is essentially calculating your remaining dose that you could safely and feasibly deliver to your organs at risk. So I'll expand on that a little bit further. So if we look at the equation near the bottom, we're looking at the cumulative equivalent dose in 2 Gray fractions remaining. So if they've received a course of, let's say, prostate, 60 Gray and 20 fractions, if you were to subtract that EQD2 from the non-recovery adjusted course, you're essentially going, well, if they've had this course of treatment today, and in a year's time, how much organ at risk recovery have we got if we were to reirradiate the prostate again? And that's calculating organ-specific recovery as well, including some radiobiological assumptions too. And this is the definition from the UK SABR Consortium from 2022. And it's a radiotherapy treatment where any organ at risk within the planned treatment has received a previous course of radiotherapy after a minimum of 6 months following the initial treatment. And in terms of standard reporting, the ESTRO and EORTC published guidance in early 2023 regarding the reporting of reirradiation and how do we look to standardize reirradiation clinical decision making, and this is what they came up with. So here's a scenario in the lung with a previous treatment in green and a new treatment in red. As you can see, they overlap, and ESTRO in their consensus define this as type 1 reirradiation. So in this scenario, we have geometrical overlap of the volume. So it could be PTV overlap. It could be the lesion that you're treating again that's recurred and you want to treat the exact same spot. And this is quite, in terms of a physics and dosimetrist point of view, a really, potentially high risk treatment course here, because the same organs at risk are quite likely to be in the same area again if you were to reirradiate. And then it's key that this second point here, with or without concern for toxicity. So without concern would apply in circumstances where there's been such a long time period between the first and second courses that you can assume quite a great deal of recovery in those surrounding organs. But in most instances, we have to apply some sort of recovery factor to ensure we're not overdosing our organs at risk. And then we move on to type 2, sort of the next most high risk clinical scenario. There's no geometrical overlap at this stage, but we're still having a concern for toxicity from accumulation of those doses. So a typical example here in sort of repeat lung SABR could be the volume receiving 20 Gray split across the lungs, and you're having to look at how much of those lungs recovered from the first and second courses, if at all. So we still have a concern for cumulative dose, even though the courses are far enough apart in terms of distance. So those are our key types of reirradiation. And then we sort of move on to repeat organ. So you could have left and right lung in this scenario. There's no geometrical overlap. There's limited to no concern for toxicity from cumulative doses, but target volumes are in the same organ. And lastly would be repeat irradiation. So you've treated the lung and then 6 months later they have a liver metastasis. It's in a different anatomical region. There's no overlap, so you can treat it as a standard oligomet, SABR or conventional plan. So this helps us to standardize the way we sort of think about reirradiation and how much recovery and uncertainty we want to factor into our RBE calculations. And we can use this sort of flow diagram here and ask yourselves these questions. Is there geometrical overlap? In any case, if there is, it's a reirradiation type 1. And this isn't something that's routinely reported as standard practice yet, but hopefully as time develops and reirradiation as is becoming more common, we can start to classify patients using this definition. So within the current landscape of reirradiation at the moment, there's a lack of consensus on the cumulative organ at risk dose constraints in EQD2. So in theory, you have your 60 gray and 20 fraction prostate treatment, you have 10 years of recovery, and then you would decide to treat with prostate reirradiation, for example. You can have that recovery applied, you can do the RBE calculation, but cumulatively over time, are there EQD2 constraints we can look to for the bladder, let's say, to give us guidance on if you've exceeded a certain amount of EQD2, you may expect a certain level or a higher risk of certain toxicity. And then an area within my own sort of PhD research at the moment is the concept of dose assessment. So how can we integrate advanced technologies into our RBE dose assessments to make them more accurate, to reduce that uncertainty? Techniques like deformable image registration, voxel-wise dose accumulation, and EQD2 planning are things we can look to do to fuse image data sets together to have a real understanding of what's going on from previous and current courses of treatment. A recurrent problem is the data availability or the lack of data in some cases. With patients who have received their previous radiotherapy many decades ago, for example, they received brachytherapy 30 years ago, and now they're coming back for further treatment. How do we reconstruct that previously delivered dose and sort of estimate in a safe way how much those organs received in the first course and how much they've recovered? And then we've got the growing emergence of MR guidance, CyberKnife, and adaptive platforms. I'll touch on that a little bit later. But the choice of treatment modality in a given scenario is going to be quite important for this technique. And then we delve into the radiobiological uncertainties. So how much recovery do you apply? If it's 5 months and 30 days, it's technically no recovery. And then 6 months, you have 30% you can apply. So maybe a personalization of that recovery in future to inform a bit more of the personalized decisions for a given patient. So here's a quick overview of the reirradiation cases we've treated at GenesisCare. And predominantly this data I'll show you in the next couple of slides will be on the MR-Linac specifically. So we've treated 156 courses of SABR Reirradiation so far. And here is the breakdown in this bar chart here, showing the different histologies that we're treating using this technique. So primarily pelvic oligomets, a couple of abdominal oligomets as well as prostate reirradiation and liver, which Cassia and Elena will touch on later. I think it's quite important to highlight as well, we try to personalize prescription doses where possible. So if a patient's referred for reirradiation in the abdomen, we'll start with a 5 fraction plan at 30 and 5, which is pretty standard reirradiation dose that's adopted, and then say, well, actually, if we're getting full PTV coverage at 30 gray and 5, can we do better with the technology we've got? So we start to incrementally increase the dose, maybe up to 40 and 5 or 45 and 5 if indicated. And here's a rough spread of those 156 courses and the range of prescriptions we've used. And same with time since previous radiotherapy, which is a key variable in our RBE calculations, with the median PTV volume size being 27.8 cc's, median number of targets often being 1. We often can do multiple target reirradiation subject to clinical background. And then the median time since previous radiotherapy is about 1.4 years. So there's an element of organ recovery there. And then to build on this further, following these 156 cases, we said, well, out of all of these, is there any possibility to boost this dose further with MR guidance? Can we escalate the dose to a safe degree whilst meeting our reirradiation tolerances and improving the overall BED, biologically effective dose that we can deliver? So across this cohort, we essentially said, well, if they received greater than or less than or equal to, 70% PTV coverage, maybe we'll just look at abdominal and thorax cases for now. And we kept trying to boost the dose until we reached an ablative threshold of around 80 gray, which is reported in the literature as a good ablative threshold for reirradiation. And what these graphs essentially show is that even across different levels of isotoxic dose escalation, we can still meet the reirradiation tolerances safely with MR guidance, whilst also improving the core dose to your GTV. I'll point here to this renal met anonymized patient here. You can see that the PTV coverage largely remained the same in red, so the minimum dose to your PTV, because we're still observing the same organ at risk tolerances for reirradiation. But by increasing your prescription dose incrementally, the core dose to your GTV is naturally also going to increase while still meeting your essential mandatory tolerances. And that's because we've got live motion tracking and gating on the MR-Linac, so we have the confidence that we can really deliver such an ablative dose to the target. And then in ESTRO 2024, we collected a bit more data since those 156 courses and evaluated the patterns of care, a bit more of a clinical focus here about primary histologies that we treated. We reclassified all these patients as per the classification types earlier and found the most common reirradiation treatment sites that we treated on the MR-Linac. And here was our poster at ESTRO 2024. And from this patterns of care data, we said, well, actually, if we can have a number of inclusion criteria for dose escalation based off histology, how many patients would that include and which sites would they be? So in this particular paper, which is quite a small review, we identified 26 patients had the potential for further isotoxic dose escalation to improve their BED to the target. And then an area of particular focus for my PhD is the concept of adaptive radiotherapy and how we can utilize that to improve the safety of the treatments we're delivering here. So the center of your screen, you'll see the new plan that we delivered, which is a combination of the previous plan in the top right-hand side and the dose accumulation at the bottom right-hand side. And essentially what that pink structure is in the center is if we're adapting and treating the node that sits above it, any organs at risk that fall within that previous treatment zone essentially receive a compromised organ at risk constraint. So we're more restrictive, we're more conservative on any organs at risk that fall within that given area on an adapted fraction, so that we can ensure, in this instance, there's vessels overlap and vessels no overlap. So you can apply an isotoxic approach. You can maximize the dose to your tumor surrounding the vessel. And then in areas where they've had previous treatment next to the vessel, we try and spare that as much as possible. And again, the process of this is quite challenging at times. Having a robust method of accumulating dose, converting to EQD2 and then to your fractionated dose as well is challenging. There's a lot of uncertainty there. And that's why we try and personalize the reirradiation cases that we encounter with a multidisciplinary team approach between clinical oncologists, physicists, dosimetrists, radiographers, and going, well, how much recovery should we apply in this scenario? Maybe there's a short time interval between course 1, course 2, and course 3. Maybe we should be more conservative here. Which alpha beta ratios do you use? What fusion techniques and dose recalculation algorithms do you apply? So this is at this stage, even at the MDT position with physics input, at the clinical decision-making stage, is dose feasible here? We have a physicist or a couple of physicists who joined the SABR MDT within the MR-Linac space, who advise, well, actually, we might need to take this offline. Let's see if we can do a mock calculation. Let's see what dose we can achieve and then report back. That's often a mechanism that works really well with the MR-Linac team at the moment. And it's something that we try to do for every reirradiation where possible. And then lastly, we're looking ahead. We really want to collect prospective real-world data. Something I'm looking to do in my PhD is prospective clinical data collection, consistent reporting mechanisms, so that we can have a larger data set of these patients that we're treating to inform future prospective trials or prospective studies. And we've collaborated with the UK National SABR Consortium with their pelvic audit doing just that. We want to, as per the last slide, improve our clinical decision making. The MDT approach is superb for the personalization of the planning, and we always want to consistently improve our RBE calculation methods in line with ESTRO recommended guidelines. And lastly, can we introduce novel technologies to improve our understanding of the previous dose delivered and make more informed decisions? Can we use artificial intelligence to inform better dose assessments? Obviously, we touched on adaptive reirradiation in the prior slides, as well as planning and background dose in EQD2 and voxel-wise dose accumulation are emerging concepts in reirradiation at the moment. And thank you very much for listening.